Okay, welcome everyone. Today we have Dr. Thomas Kannampallil. Dr. Thomas Kannampallil is an associate professor of anesthesiology at the Washington University School of Medicine and the chief data scientist and the assistant dean for data science for WashU Medicine. His research interests lie at the intersection of computer science, cognitive science, and clinical informatics. Specifically, his research focuses on developing and evaluating intelligent computational tools and building behavioral phenotypes for improving clinical decision-making and patient safety. Thomas's research is currently funded by multiple R01s from the National Library of Medicine, National Institute of Aging, and the Agency for Healthcare Research and Quality. And with that, I'm happy to give it over to Thomas.
Thank you. Andre, can everybody hear me? Just want to make sure. Awesome. Thank you, Andre, for that introduction. I just want to say, my academic role is as an associate professor of anesthesiology, and I have a joint appointment in the Department of Computer Science, and I'm neither an anesthesiologist or a computer scientist. I'm a clinical informaticist by training. I know some of you, Wimla was my mentor or still is my mentor. So some of this work has evolved since the early work that I've done with Wimla and others on sort of the cognitive underpinnings of the work. Can everybody see my screen? I can't see the chat, so I just want to say, feel free to put questions in the chat. Andre will moderate that. I can also have some places for where I can pause, because this is a set of studies that I've done over the past 4 or 5 years. So this is there are sort of natural places for me to stop. Some financial disclosures, not related to this work. Ongoing research, some of which I'll talk about with respect to these. I also want to say I'm in a department of anesthesiology, and my role primarily is to build perioperative informatics within the space. It's a kind of a challenging area because of a number of reasons. But what I've transformed myself in the last 5 years or so is to be a sort of a moving from the idea of building tools to a pragmatic trialist. And you'll see a little bit in a number of areas that I've developed tools, but primarily my focus has been on building these informatics tools, especially tools that have artificial intelligence into them, into sort of pragmatic trials. So I won't talk about any of that today. Also on behavioral medicine. What I'm going to talk today is on audit logs. How many of you have just broadly, how many of you have heard the word audit logs since you've been at Columbia? Okay, fairly well known topic, but it's taken an added importance in the last several years due to a number of reasons, right? Like almost all clinical work passes through the EHR in one way or the other. Orders, documentation, at least part of the communication. And there's also evidence that physicians spend approximately 50% of their time within the EHR, which makes it a central point in which of their work activities. So within this focus, if you think about audit logs are a way to measure activities within the EHR. They originally came as part of the ARRA in 2009, which were mandated for security reasons and also for tracking, who performed what on which patient. So if you look at the image on the side, which is completely de-identified, you can see there's a bunch of there's a time measure, there's a sort of a user ID attached with who is performing the action and the patient attached to it. And you can see over the course of that approximately 4-minute interactions, a number of activities are performed. These are automatically recorded on the back end. It provides an opportunity to characterize what the clinician is doing, especially given the amount of time clinicians spend on the EHR. In general, it's been considered sort of the fingerprint of clinician work with various levels of control that you can attach to those audit logs. It's been used in a number of studies since, I want to say, 2015, 2016, and the rigor of those studies have expanded over time. For example, the study was essentially a descriptive characterization of the amount of time the physician split between the use of a EHR versus talking to the patient. It's been generally characterized as article written in the Journal of Biomedical Informatics about 5 years ago, was sort of foretelling the importance of audit logs as a gold mine of health services research, especially within the space where you can think about how to use it. But till date, till 2020, when this article was published, much of the work was purely characterization, and it took a while for it to differentiate from characterization to assessing it, to study a set of outcomes, or how does it affect behaviors within clinical workflows. So let me take a step back and introduce, you might have heard what audit logs are. The standard and the definition of what an audit log is has varied significantly over the last several years. There is a little more concentration of what these actually mean. So primarily, when in the past, when people referred to audit logs, it was essentially what the vendor provided as a summary of results based on their underlying calculations on time spent on the various aspects of an electronic health record. So, for example, Epic has its own product called Signal, which, if you have access to Epic, you can actually go in and see where the different metrics related to time spent on orders, time spent on the EHR, time spent on various activities within the workflow. And it's been used extensively, especially early on in the research on utilizing audit logs to characterize different versions. It's really easy to use, but it's completely dependent on what the vendors provide, and there's a lack of transparency in its measurement, in terms of how they create these measures and metrics over that. In contrast to that, which I referred to originally earlier on, this example, when actions are performed on the EHR, it also creates an audit event of sorts, which is in terms of raw events within the electronic health record. The advantage of this is that it gives you it prevents you from using the standardized boxed actions that are provided by Signal or Cerner's advanced version. You're able to develop your own set of metrics associated with that. The challenge with it is that you have to spend a considerable amount of time in order to assess how appropriate measures, for example, time spent on an action, time spent on a task, time spent on orders, that you have to decipher what these metric names basically mean in order to create a summary of the actions or summary of the workflow. It's also provides opportunity to create new ways to apply data science related machine learning approaches in order to use it, because it's the largest table in Clarity, which is the Epic's database. So, 15 billion rows. I made these slides a few months ago. It's over 30 billion rows right now, and it's expanding on a day-to-day basis. Just to give an example, an inpatient physician creates about 1,000 events a day. So it's just constantly, if you look at a large healthcare system, it's constantly expanding, and it provides an opportunity. So there is a contrasting balance between an opportunity and also a challenge of how to take into account some of these considerations of action events into meaningful measures that you can use to address a number of problems that clinicians and also patients face with respect to the use of the EHR. So when we started this work, and I want to say I got into the deep end of audit logs during the beginning of the pandemic, when a lot of the other work was sort of paused. It was also well timed in the sense that the National Academy of Medicine's Taking Action Against Clinician Burnout report came out late in 2019, and that presented an opportunity to think about what does it mean to study audit logs within the context of healthcare or clinician behaviors. So the framework that what the National Academy of Medicine report came out was this systems-oriented approach, which was that the work-related factors associated in a clinical environment was affected by both the individual factors associated with the clinician and the external organizational factors associated with the clinical environment. So, for example, rules, the culture, factors that were external to the individual. And then both of those work-related, the clinician environment and the individual factors affected the work-related aspects. And their argument from the systems-oriented perspective was that both of these equally contributed from a systems level into physician burnout, which also indirectly then contributed to patient safety. So this was in some way a sort of a 30,000 foot perspective that we decided to start using. Again, click, yeah. Decided to use in order to account for audit log. Can we use audit logs to measure different aspects of the work-related factors, taking into account both the clinical environment and the individual factors together, to study, both patient safety outcomes and also, physician clinician related outcomes. So in some ways, this was sort of our initial perspective on thinking about this. So the argument that we had and we made was that the work-related factors can be, to a certain extent, captured with audit log events. So, for example, what's the type of activity? How much time is spent in that activity? Can you take into account other aspects related to the individual patient when you account for some of these activities, things that you can capture directly from the EHR. And then there was also individual factors, as you can see from here, that you can also capture from other aspects of the electronic, other aspects such as, for example, how much, what is the experience of the clinician, the emotional well-being, and these might need additional metrics that are not available in the EHR. And the idea still was that work-related factors contribute to potential errors. Both the combination of the individual factors and the work-related factors potentially contribute to burnout. This was sort of our high-level perspective, which we published in JAMIA several years ago. And this was sort of the fundamental framework that we started this work on audit logs. So broadly speaking, our framework on the use of audit logs, right, was fairly systematically simple. It used a systems-oriented approach. The fact that we can use these audit events, a large volume of audit events, to characterize workload or other metrics associated with the work on the EHR or in a clinical setting. And our assumption there was that we can use that to assess clinician-related factors such as burnout and other workload-related elements. And we can also use that to assess medication errors. And I'll get into a little bit more about what specifically we were thinking about. Specifically thinking about a class of errors called wrong patient ordering errors. And can be assess these metrics in order to use these metrics in order to find associations between work-related characteristics and outcomes. And also this framework also naturally provided the ability to say, hey, can we build predictive models? Can we use machine learning type of models within these activity sequences in order to predict burnout and/or errors? And just to preview, some of this is extremely challenging because clinical work is extremely complex, but it provides opportunity to start. I'll pause here for 1 second. I can't see the chat, so Andre, if there are any questions in the chat, I'm happy to answer before we move on, or I can move on to.
So far, no questions in the chat.
Okay, thank you. So what I'm going to do for the rest of this talk is, it's not a single study. I have about 10, 12 studies. I'm not going to go into specific details of those specific studies, but they're all connected with the use of audit logs and measurement, and how can we use and sort of expanding the scope of how we can use audit logs to do a number of things related to clinician work and outcomes. So the first study, this is drawing on work that Vimla has done in the past on measuring clinical workload in sort of high frequency settings or highly complex settings. So one of the basic assumptions that we started this study is that attention switching or task switching broadly is common during work activities. So for example, so some of these actions are sometimes opportunistic. So you're reading an email and your phone rings. You pick up the phone. That's sort of an interruptive activity. It could also be opportunistic. You're writing an email and then suddenly you think of, oh, I need to pay my my bill. So you switch to your phone app and then move to doing it. So again, while attention switching is common, the underlying reasons for that attention switching varies. It could be opportunistic versus some sort of interruptive activity. But the fact is that across the board, attention switching or task switching leads to increased cognitive load. So, for example, these studies were done in a set of psychology related experiments over long periods of time, which essentially showed that the likelihood of errors and increased cognitive load was associated between switch and non-switch tasks. So, for example, the simple example is that people were asked to count from 1 to 10, and then at some point asked to stop, and then switch the task to going in order A through Z. So what was found in these experiments, and there's been a number of experiments that have been done, which have shown that the switch between one task to another task increases the cognitive load associated with the switch in that immediate time point, and increases the likelihood of errors in the switched task. So it's a very simple kind of concept, and it's fairly simple. So you're writing an email, suddenly you have to switch to reading a note from a Word document. That switch, while that the point of the switch increases the cognitive load, you'll normalize it over a period of time, and that switch period increases the workload. So the basic assumption was that we have this problem of decreased efficiency and longer task duration times in general for tasks that are actually switched. There's also, as I said before, the increased risk of errors. So don't know if this will actually play out. So we defined cognitive load from the context of a patient switch. So if you switch between patients during a continuous task, we wanted to assume that was an attention switch, and it increased the cognitive load associated with that switch. So let me take a simple example here. So here you see a person, this clinician working on a patient A, till about 6:32 a.m. and then switched to another patient, patient B. And then we defined this switch, which did not have a long break in between. We used a standardized time split, about 5 minutes. And you can see that that person starts to a switch. So that we counted as a switch, as an attention switch. And if there was like long breaks between here, so for example, 6:36, they stopped at patient B, and then the next task started at 6:45, which is more than the 5 minute sort of barrier that we used. We considered that as a new session and not attached to an attention switch. So essentially, we were counting large amount, using these sort of audit events to assess patient switching and as a proxy for cognitive load associated with the tasks. So, and our goal was to measure the association between attention switching and efficiency and errors in an ICU. And the metric for work efficiency, we use total EHR time, which is basically the time spent on an EHR at a day level. And the errors we used, and I'll explain a little bit about, we use wrong patient ordering error. A wrong patient ordering error, which is developed by some of our colleagues at Columbia, Jason Edelman, was the idea that if you order a drug on a patient, retract it, meaning cancel it within the next 10 minutes, and then reorder that same drug on a second patient within the next 10 minutes, it has over an 84% positive predictive value of being a wrong patient ordering error. Fairly simple. It's been validated in a number of studies. Jason's done a number of studies. I've been involved in a number of studies where we've done sort of prospective validation of this. So it's a pretty powerful mechanism. The advantage of using wrong patient errors is that it gives the opportunity to automatically measure this because it's based on some sort of metrics associated with actions. But the disadvantage is that it's a specific kind of error attached to a wrong patient order. And it's also a near miss error. Only 2% of the wrong patient ordering errors actually reach the patient. So it's a class of errors which you would call as near misses. So again, without going into details of this, very complex setup of data and all that, this was run in 4 surgical ICUs at WashU and BJC. And it was we primarily looked at attending physicians and APPs. And the reason for using attending physicians and APPs, residents from both anesthesia and surgery worked in these ICUs, and it changed a lot. So we wanted to have some consistency in the measurement. So like you see here, this was a 1-year data set. And you can see the volume of data that we use, like 62,000 hours of EHR work, typically, which we would do by observational studies. And we're trying to replicate the idea that there is the attention switching increases the work. So you can see here, physicians and APPs, 95 people were working in those units, a large amount of actions. And then you can see that we created a number of measures related to time spent on the EHR. So I'll go through some of them, not all of them. So number of patients viewed per day, which is again essentially based on the audit events, number of actions that were performed on the EHR. Messaging, messaging doesn't happen a lot with the APPs. Ordering sessions, again, attendings don't do a number of ordering sessions, mostly done by the trainees. But you can also see things that have an impact: time spent on the notes, time spent on reviewing, number of patient notes signed in a day, sort of showing on how much they were involved in the patient care process. So again, these metrics, again, directly from the sort of 62,000 hours of clinical time. So I'm going to go directly to the result. We used a mixed effects regression model because people repeated the task, they worked across the board. What we found is that for APPs, an increase of switching from 25th to the 75th percentile per 100 EHR actions increased their total EHR time by 0.28 hours per day, or approximately a 7% increase on a daily basis with respect to the increased time based on like increased attention switching. We did not find any effect on the attending physicians, which was expected. But more concerningly, I want to say, this 25th to 75th percentile increase also increased the wrong patient error rate among APPs by 28%. Again, this was a substantial number. This paper was published many years ago. But the point I wanted to make is the ability of us to do sort of high-level retrospective observational studies on measuring a phenomena that we know has strong theoretical background or theoretical underpinnings in order to assess its impact on downstream actions of both like the efficiency of work. Does it increase the workload? Does being distracted or being distracted in a complex workplace affect? Again, there are several limitations. One, these measures are not perfect in terms of the metrics, in terms of assessment that we created. And we also don't know all the measures of attention switching. We only know those that happen in the EHR. There could have been other things like phones going off, pagers. And we also don't know the underlying cause of the attention switching. It could be opportunistic or based on some sort of interruption. Again, still provides an initial perspective on how to measure. So this was both the methodological perspective to translate the idea of task or attention switching into this framework, and also attaching it to downstream outcomes with respect to work.
And just to
before I move on, I'll pause for a second. Yes, Sarah.
Thank you. That there are some questions in the chat. I think your limitation slide just answered some of them, but they're really about, are there gold standard metrics for this type of log file data? And overall the questions are talking about standards and standard ways to look at this data.
Yeah, no, and those are all fair questions, and it only gives a proxy for assessing is it related to some sort of workload-based measures, known measures of workload? We also, the thing to remember in these task switching studies is that it increases the cognitive load only at the transitional state. Then people normalize, right? Like, so if I'm like, just like you take the example of counting from 1 to 10 to switch to ABCD, or counting from Z backwards. Right? Like the effect is only when you start the task. And that's what all of these studies, it's the switch task which increases the work, cognitive load, and then people normalize and get to the next task. But the more switches you have, the likelihood of those transitions are more increasing. So it's based on a theoretical argument. There is no gold standard. And it's very hard to assess that gold standard. I mean, we could do observational studies. I think the point I want to make here is the scale, right? Like, so you go from doing it for 30 hours or 60 hours or 80 hours in a gold standard way to 1 year with 100 stable participants in the unit.
And one more question just put into the chat, which I think contextualizes this a little bit more too, and what you were kind of saying, the number of switches that happen. And the question's talking about, is this when you switch between patients?
Correct.
But is it also within one patient case?
Right. So that's a really important question. So, and I'll get to the part about switching within the patient, right? So in this case, we're talking specifically switching between patients. The problem with audit logs and a challenge across the board is to assess when a task begins and when a task ends. It's really, really hard, and it's a very approximate measurement. So identifying tasks, which we have done not by action. So we try to manually code events and to see, hey, here's where a task begins, here's where a task ends. And it's very, very hard, and it's very approximate because there is no standard path within an EHR in order to complete a task. And people differ so much in how they complete the task. So it's impossible to do that. We tried, and I'll get to this construct. We try to build this construct or theoretical construct. That paper is coming out in PNAS in a few days. Is on using action as a language construct, right? Like, so we have these action events, and we're trying to build, like, can you identify these tasks based on actions? Because people have certain phenotypes in which they perform these actions. So we've tried to do that, but no, it's not basically with respect to tasks. And I agree with you, there is potentially some confounding when people switch between tasks, but the boundaries of the task are harder to define. Any other thoughts, questions before I move on? All right, so this was sort of our first, and it was exciting. This was 2020, a lot of free time, especially if you're a non-physician, in order to do all of these things. And so what we wanted to do was like, okay, if we can actually do these sort of measurements within the EHR at scale, not a few patients, but a few physicians, but hundreds of clinicians, is there a potential to do other sort of downstream impacts of workload measurements? So, again, the National Academy of Medicine report came during that same time period about burnout and sort of the effects of burnout. Like, I don't need to explain to a informatics crowd on the impact of workload on burnout. And often the EHR is described as a potential source that contributes to burnout. But here's the problem with measurement of burnout. Burnout's almost exclusively, even today, using surveys. And then our assumption, and it's always almost cross-sectional, usually, the standardized, the MASLAC burnout inventory, which is almost standardized, usually is done at a 1-year scale. And if you look at the surveys that have been done across the board, they'll say, hey, in the past year, on a number of metrics. And it's always cross-sectional. So our question really underlying this was that, if audit logs can be used to measure workload-related metrics, can you use it to screen for burnout? A very broad, high-level question. And our assumption was that based on our initial results of measurement, we could probably do it. And the idea here was similar to the work that was done before in behavioral modeling using behavior modeling of depression and anxiety and these sort of other clinical constructs with respect to using wearable devices and these sort of behavioral phenotypes from there. So the assumption is that like depression and anxiety are related to things like sleep disruption, sleep deprivation, fatigue, of lesser psychomotor activity, increased stress, right? Like, and even below that, there are certain activities that are associated with like fatigue, right? Like less movement, things like that. So in the same construct, our focus with respect to burnout was similar, right? If you think of burnout as the construct similar to behavioral outcome that we were looking at, workload and other sort of factors associated with workload, like concentration, efficiency, can be are contributors to burnout. And below that, you can get to patterns of can we use patterns of EHR use from audit logs to measure these sort of metrics, right? Like, so what are the workload feeders? And we've done quite a bit of work by this time in order to measure metrics related to workload features and sort of also temporal features. So this is where we started with. And then we started, we conducted this prospective study, primarily with trainees, interns really, because this was in I want to say September. We started the study September of 2020. Peak COVID, before the vaccine. And so we had to do this we wanted to do this with attending physicians, but it was almost impossible to do. So we started the study. And the novelty of the study was that we were not going to do just one cross-sectional data point. We were going to recruit trainees in 3 disciplines, and they were going to complete, all they were going to do is to complete the standardized burnout survey called Stanford PFI, the Professional Fulfillment Index, which has been shown efficacy for measuring burnout. And we were going to measure every month. And all the participants had to do was to do this 2-minute survey and then move on. The advantage of using the PFI was that it had a 2-week sensitivity, meaning that it was asking the questions in the past 2 weeks. So it's also aligned to the task. We also timed these measurements with respect to when they would get it aligned with their blocks, switching across blocks. So, so there was 104 eligible participants, 75 agreed, and you can see our completion rate was like 78%, which never happens in trainee studies, and this is mostly instant gratification. So basically, when they completed a survey, they just got a $10 gift card, like immediately, right? Like we had set up this very expansive mechanism in order to do this. And the measurement mechanism was easy for them, which was essentially a 2-minute survey at every month. The primary outcome was the burnout score measured with the PFI. We also had the secondary outcome of wrong patient errors. Any questions?
There is one question in the chat. Have you worked on or designed active systems that analyze audit logs in real time to predict potential errors and, for example, prompt physicians to review their work again when the risk is high?
Yeah, so yes and no. So this is such a massive sample in real time. Okay, so if I need to answer that properly, I'll have to get into the infrastructure of how Epic is set up. So Epic's real-time mechanism is called Chronicles, which stores a combination of mouse movements, keystrokes, and what happens from Chronicles is that overnight these Chronicle high-frequency data elements are transitioned into the standardized Epic format into a database called Clarity. And all of these analyses were done using tables that were stored in Clarity, not in Chronicles, right? So the Clarity tables are about 24 hours old by the time you get it, right? Like, so the real-time analysis from Clarity is not possible. You can do it almost retrospective by the time you get it. We have attempted to do some of these things in Chronicles. It is just computationally very expensive and very complicated in order to run this in real time. But there are ways in which some of those things don't need to happen on a real-time basis. Like, for example, burnout. If you're using this as a screening tool for burnout, you can do this at weekly intervals and run the algorithms. If you build a machine learning model for predicting who's likely trending towards burnout, you don't need to run it in real time. And I also don't think computationally it's a reasonable thing to run these sort of data elements in a real-time basis. That's just a broad perspective based on years of working with these sort of things. Okay. I'll move on. So this is the PFI scale, which was used for the surveys, and it has 3 components, and the last 2, the emotional exhaustion and the depersonalization scales, which are aligned with the MASLAC burnout inventory. It's been shown to be correlated with burnout. So that's sort of the measurement we use. So just to give you some summary, the sort of EHR measures on the right that you see here were similar to the ones that I showed you in the previous study on the cognitive load. Number of patients they did, time spent on ordering, time spent on notes, time spent on average time per day per patient in various activities. There's also average total time spent per month on the EHR in total. So again, measures related to activities that we can identify. So what did we find? Essentially, again, we did a linear mixed effects model. With every participants, 75 participants in the study. They worked in different units, so we had to do sort of nesting in what they did. What you find here is that, burnout score varied considerably across the time, varied across the time. But if you look at the survey numbers between people, but if I take a single example, and this is just one participant, you can see this person went from inpatient to clinic to inpatient to clinic to the ICU to an elective. And you can also see, like, the red one is the burnout score. The blue lines are various measures related to workload, like total EHR time, patients per day, and review time. You can almost see here that the burnout was sort of related to where they were inpatient. Not surprisingly, the inpatient sessions were more hectic, more workload, and the burnout sort of aligned to that. So, strangely enough, these burnout scores were, or actually not surprisingly, the burnout score was surprisingly elastic. And, the analysis also showed, right, like, so the multivariable mixed effects model showed that burnout was predicted by, the time you spend in the EHR, how many patients you handled, and the time you spend reviewing things. Strangely enough, inbox time was a protective, but that's because many of the trainees at WashU, this is primarily an inpatient setting of the work, and they don't get that many in-basket messages. And there was only very few retract and reorder wrong patient events. There was no association between work activities and wrong patient errors. So again, in broadly enough from statistical analysis, we found that, like, the work hours or some sort of patient complexity efficiency metrics related to the amount of time you spend on reviewing a patient was associated with burnout, which was, in some ways not super surprising, but kind of exciting, showing that there are some phenotypes of behaviors underlying in the audit log from the measures that we were using, showing that it's possible to potentially identify burnout or using these sort of audit log events as screeners for identifying burnout in participants. Again, promising. But there's lots of things to consider. The limitations I will highlight again and again. This was with trainees. There's large fluctuations. They were still getting used to being in a clinical setting. It's not ideal. There's also things related to how they work. But many of the trainees were, we started the study in September. They had finished off all of the EHR sort of training and things like that. So that's there. The paper was published, I want to say 2021 or early 2022 on the sort of the temporal associations with the workload and burnout in JGIM. And then the more important thing for us was that, our final goal in this study, again, this was a pilot study for preparing for a grant submission. Our underlying question was that, can you use these audit events as a screening tool if you can build machine learning models to predict burnout? So, okay, the statistical results sounded exciting, sort of exciting, not surprising. So we were sort of propelled to see, hey, can we predict these? So we took off-the-shelf models, right? Like, to see, hey, so sort of feature engineering into some of the features associated with the action behaviors over we took time periods like the month before and the burnout being the outcome. And we tried to do these models. It failed miserably. Like, not we were surprised in the beginning, but most of these models, right? Like, if you consider just the workload elements, right? Like, the best performing model at an AORC of 0.6, less than 0.6. If you consider sort of the temporal aspects in terms of incorporating some of these measures into the work and combining it workload, still performed really bad. But here's the thing. So if you just take the first survey score, that predicted burnout, right? So what it actually shows is that, the survey score, which was, self-reported, had better predictive capabilities than some of those measures. So why was this happening, right? Like, and the biggest point in this, we, sort of, the sort of things that we took out from this was like, It's an extremely complex prediction construct, and the audit logs only capture a very small amount of the complexity associated with the interaction, right? So burnout, for example, is a multifactorial problem that usually comes from not just from working on the EHR, although it's a big factor. It's also about the patients you handle, your things that happen at home, working with your colleagues, and a combination of factors that combine, which the action events per se does not. This is also a function of why it didn't work out with respect to why these predictions didn't work out was also associated with, but some of these folks worked in different settings, and month to month it varied significantly in terms of the burnout score, like I showed in the example. So the models got confused. So, for the same work, these people do different kinds of work, and the model variation in the burnout was different. There's also individual factors that we could not capture with these. I mean, it's also impossible to capture these, right? If I'm a physician, I can work 80 hours and not feel burnout, but somebody else could work 40 hours and felt burned out. So these sort of constructs were harder to incorporate in the model, and most importantly, the sample sizes were there. We wrote a really nice, lessons learned on using clinical activity logs on prediction in JBIs several years ago, and that sort of highlights the challenges of using these sort of approaches. I had some colleagues in computer science who were like, maybe it's because of the off-the-shelf models that we're using that weren't. So they wanted to use sort of a deep learning approach, and I'm going to skip through the details, but the story is that no, it really does not work. So even though we were sort of adamant that it's not going to improve significantly the performance of very complex models, taking into account individual actions, scrambling them into sequences, and trying to predict barely improved, like 2.63 on the best performing models. This was one of the SIG-KDD best papers in 2023 on a deep learning framework for a burnout prediction. Again, broadly, I use this as a sort of a cautionary example on how to study these sort of behavioral aspects from temporal sequences of work. These are very, very hard problems that are not just captured by actions alone. And I'm just trying to put caution in trying to explain this. I'll pause here for a moment if there are questions, which I can't see in the chat.
Thomas, you
Yes.
use two concepts interchangeably: the workflow and the workload and the cognitive load. Are there any differences between the two?
Yeah.
Or is it the same?
Yeah, no, that's a very, very important question. So I did use them interchangeably, at least in the first study, where I was specifically referring to cognitive load alone. In the measurement-based metrics on burnout, we were just generally referring to these as workload because we could not specifically get to specific aspects of cognitive load associated with it, right? So it's a fair differentiation. We did look at we have consistently used patient switching as sort of a metric, patient attention switching as a metric for as a proxy for cognitive load. Is it truly cognitive load? I don't think we can actually measure in this setup. Chris? I think Chris is his hand.
Hi. Yes. I have a question regarding the surveys that were used to interview the physicians about their workload.
They completed a survey remote, virtually, meaning they were sent a survey at a 10-minute, 2-minute survey.
My question is, are the physicians informed that these surveys are private and de-identified?
Yes.
Okay.
Yeah, this is an IRB approved study where, so I can get into details of how we actually ran that. So none of the burnout scores or any of the measures that were collected, including the workload metrics, was shared with anybody besides like 5 or 6 of us on the study, right? It was also the program directors who were involved in the study while they helped in the recruitment process, had no access to anything. So yes, they were consented, and they consented to participate. And if they consented to participate, they provided two things: access to the audit logs, agreed to complete the surveys. Does that answer your question, Chris?
Yes, yes, thank you very much. I asked the question mostly because I saw on that survey slide some of those questions, if they were not de-identified, they seem pretty
Yes.
loaded.
Yes, they are. They are. Yes, absolutely. And I also want to say, right, like, so when we matched the individual burnout scores to their audit actions, it was all done by proxy, meaning we had a subject ID and not with their usernames and things like that. So essentially, the only thing we're using the actual Epic user IDs were to get the data.
Thank you.
Okay.
Just to add to that, Chris, some of these studies very earlier, the early phases, not the new ones, is talking about, we had a certificate of confidentiality, which really meant that anything physicians or clinicians, anybody who said anything or we recorded anything is not reported, cannot be reported in a court of law. So we were very lucky at that time. We had a 6-year certificate of confidentiality. These days is much more difficult to get that. So we have to, as Thomas described, you do it individually, as if an individual survey, individual studies, and that's so that's one way of getting around it.
Yeah. In my first study that I ever did in informatics in 2010 with Vimla, we had a NIH certificate of confidentiality. I still remember those studies in the ICU. I think NIH has stopped giving certificate of confidentiality as of this year to do any of those studies. Yeah, so there's lots of changes. Okay, so just to move on, so we started the study with this sort of broad framework, and now we started, like, you can see how those various factors were incorporated into the sort of work-related factors which would capture, and also some of the patient or personal factors into the framework, and these can potentially provide some directions for the future. So this is, so this was again, so what next is kind of dated. When we reached the end of the study, we submitted an AHRQ grant, which was funded, which is a large multi-site, 3-site study. We also had some other extensions to this. And I want to say, I want to very briefly go through sort of the pragmatic extensions that we took from this study into other sort of applications for it. The first one was, like, my colleague Sunny Liu, who was a trainee at that point, cardiothoracic anesthesiologist. She wanted to see, hey, can we use EHR-based work activities to assess to RVU or reimbursement models? And what she did was she took 6 months of data from 11 hospitals and CRNAs and residents to assess, when do anesthesiologists do the work, and how much of their work, anesthesiology billing, and not to go into the details of anesthesia billing, there are some metrics related with standardized metrics related to anesthesia billing. So we build this model framework on, the billing was based on anesthesia duration, some base units for the procedure that was done, and an ASA score modifier, which is essentially a reflection of the complexity associated with the patient, and compared that with, how much, with the total clicks that were done per case. And we found that the anesthesia, the procedural base units were often undercounting the amount of time that they were doing. So this was published in JAMA Network Open a couple of years ago, essentially looking at combining these sort of action metrics into RVUs. And we've always looked for expansions of this into inpatient medicine or outpatient medicine. Just didn't have the sort of clinical collaborators here, but the methodology that we developed into assess click-based actions into outcomes that can be measured like RVUs is a sort of a generalizable approach, sort of an extension on using audit logs. Moving away from specifically looking at physician outcomes, this is much more on a broader scale. We also started to look at, this was with Julia Adler-Milstein at UCSF. Julia and I wrote an R01 for a National Library of Medicine, this is right at the transitional point of COVID, to look at Are there differences in telemedicine-based work versus face-to-face work, specifically looking at cognitive and sort of process outcomes with respect to that, at a sort of a two-site study, right? Are there differences in way clinicians document, search or review, or use external tools for communications with respect to telemedicine and face-to-face encounters? The first paper of that just came out. Nigel, who just graduated and looking for a job, just started this work. This was a two-site study, basically looking at, are there differences between telemedicine and sort of face-to-face encounters? So this was also this was useful. The project's going along. We also wanted to look at whether can you combine audit log events with other known healthcare worker activities? So, for example, one of the things that sort of naturally happened was this idea of using secure messaging. Secure messaging is basically Teams for the EHR. So Epic has its own chat interface, secure communication interface. So if there are physicians in the room, I don't know if Columbia uses it, has this chat called Epic Secure Chat. So what we wanted to do is to see, hey, the secure chat has, it's typically used for communicating patient-related information across clinicians. So we started to look at metrics related to secure messaging. There's fundamentally very broad differences between secure messaging. There are differences in secure messaging patterns. All of this we can get from the metadata associated with secure messaging, which is like who sent the message to who, when was it opened, how many characters, when was it read. Probably the most interesting thing for us was, it was most messages across our institution, about 50 million messages read or actually accessed within the first 29 seconds it's received. So it actually gave us the first option of looking at a true interruptive event at scale within the entire health system. So we published some work on that. This was exciting. But there was really a question of, can these activities be measured even more in depth? So, for example, the sort of questions that we wanted to answer required a combination of, like, does messaging lead to increased clinical workload, meaning that does it make you work more on a day? Does messaging on using these sort of tools increase or reduce your use of your phone or pagers or things like that? And then finally, we also wanted to look at things like, does it lead to fewer wrong patient errors? Meaning that if these things are so interruptive and the volume is so high, on average, a physician gets, in our institution, an inpatient gets anywhere between 20 and 40 messages a day. And in terms of volume, it becomes increasingly high. And some of also for nursing folks, we've seen that the range varies considerably, and it actually gets into their affects their practice. So the idea here was that, not to get into the details of the results per se, the idea was that, if you look at just secure messaging as a data resource or data repository, you're limited by the ability to assess what it affects in terms of work. So we wanted to combine the audit events associated with these secure messages in order to combine and see what really happened. So this study, we took a 3-month sample of secure messaging data across almost 3,500 physicians, clinicians, 2,000 attending, 564 trainees, and about 1,000 APPs. And we combined, how much time did they spend on the EHR with respect to their secure messaging volume. Also, you can see trainees send way more secure messaging than sort of the attending physicians and the APPs in their cycle. And we wanted to look at the outcome related to, does it affect their workload? So what we found was that, across all three groups, the increase in secure messaging volume was associated with an increase in time spent on the day, showing this is, again, sort of the somebody was asking about the task switching construct and sort of the interruption construct. We looked at the framework to see, does receiving more messages increase your work that you're doing on the EHR. Remember, the fact that you receive a message also might be related to an action that you might have to perform with respect to a patient. Somebody's requesting something, putting in an order, or delivering a medication. So you could see that the scale defect estimates across all three groups was increasing over the period of time. It also showed that if you receive more messages, you're actually potentially more increasing your cognitive load. So the increase in the messages will also increase additional 17.3 patient switches, which also shows the idea that you get more messages, it's unrelated to the patient or the work that you're doing, and you have to switch to another patient to perform a task. Again, I just want to extremely be clear about this, that this is associative, not causal. Again, but based on millions of millions of messages. What did we also find? There was also a 10% increase in wrong patient ordering errors with the increase in the increased messaging volume also increased, right? So again, very interesting stuff. These papers are now published, both of the first two, and the third one, which we thought was sort of, our hypothesis was proved wrong, which was, we assumed that having a new mode of communication, which is easy and asynchronous, would reduce other forms of communication, like telephone use. But incidentally, it doesn't. You have more forms of communication. People use more forms of communication with all sort of sources, right? Like, so if having the secure messaging, people were like, if you didn't respond, you move on to the next one too, potentially. Again, cautioning that this is associative. And the last thing I want to say is what somebody asked earlier about, like, can you determine what sort of tasks are performed within the sequence? Manually coding these seems like the easiest step. There's about 1,500 unique actions in the metric events in the audit logs. So we thought like we could manually code them. But the problem was that the manual coding would not scale up because people could take different paths in order to writing a note or doing a review or putting in an order, which made it like sort of the standardized gold standard manual process immediately impossible. So we started looking at sort of algorithmic techniques, which sort of started with sort of these unsupervised mechanisms like action embeddings, to embed sort of like what is the underlying task associated with a set of actions that are associated. These were useful, again, at scale. This paper was useful in trying to characterize the set of actions in a specific context, but it just did not scale. So what did we do? So we started, Nigel's thesis is this action as a language construct. So the construct that Nigel and I were working together in this idea that, just like human language has a certain structure, the action sequences of experts also have a certain strategic structure associated with it. Thomas uses his email in a certain form, and over time there's a structural similarity or consistency in that action sequence. There might be differences, and the idea was that you can use action as a principled mechanism to study language, although it's not in the same construct as you would say Italian as a language, or what the grammatical structures are. But there are, at an individual level, a sort of strategic equivalence in actions that helps people characterize language. So the broad question was like, can you use audit log action sequences to study from the perspective of a language model? So the initial work we started was that, if you have a certain strategic approach that you use, your sequences in an uninterrupted or in a normal sequence, routine sequence, would be very structured. You would always order in a certain way. You would put a note in rather similar ways at scale. But if you're interrupted during that task, or if you have some sort of deviations from that task, or what we would, there would be an entropy associated with those actions, and that entropy becomes a way in order to characterize that there is some sort of a non-routineness in these sort of tasks. So this was like the simplest idea that we started with, and it's gotten way more complicated down the line. We're trying to come up with a foundation model of sorts to explain this. So we started with this idea, and we try to look at assess. Is there a difference between routineness and non-routineness by a language model at an individual, and we found some interesting results. And you could capture the action entropy as a metric in order to characterize this. So, and we've done some additional work now, which we build a foundation model, and we're trying to come up with a broad, explanation of action as a language framework for studying behaviors using large language models. And you'll see that paper out fairly soon. And I want to end with this, where are we with respect to audit logs? We've done, there's several institutions, academic institutions have taken a lead on these sort of audit log-based studies, but we're still lacking large-scale multi-center studies, mostly because of the regulatory issues around large-scale data sharing. Julie and I wrote this article last year, but like, how do we scale up from this to a much more broader perspective on using EHR audit logs and making it much more useful? There's also a lack of standardization of models. We also need to think about, as an academic group, we've always shared all our data pipelines. So if you're looking to get started, we have a private GitHub that we can share, including Clarity queries in order to do this. We also need to think more broadly into expanding this into more structured ways using computational techniques. I will stop here. I appreciate the opportunity to be here. This is not my work. This is a bunch of my team who've worked at different points with my group. I really appreciate the opportunity to be here. Thank you, Sarah and Vimla, for inviting me. Thank you very much.
Thank you very much, Thomas. I think an additional question or two.
I took off the slides so that I can see people.
And we've realized we're a minute over time. If you have to leave, please go ahead. Thomas, this was so fabulous. So if anybody has a question and wants to stay on, please, if you have a couple minutes.
Yeah, I'm okay. I don't have.
You don't have anything to do.
I don't have, apparently.
But we realize others might have meetings to go to. Can I ask one question then?
Yes. I also want to say, Sarah, we did something recently, which we took audit log events of 500 nursing staff. Nurses are not part of the academic medical center. They're part of the hospital attached. Similar to New York Presbyterian, right? And we had their turnover data, and we could predict turnover based on workload related measures. Again, I just don't think that's the only reason why people move. And it's like an incomplete picture, but it gives you a start point to do that. So there's lots of side things that we've done, which may not have a long-term use, but it's a provocative set of hypothesis generating constructs that we can derive from this.
Have you considered with the use, the coming use, and it's in pilot form in many ways, of ambient technology, how that may impact your current methods, the additional data needed, or do you anticipate log files will still be capturing the essential information?
I can speak for hours about ambient. We have a perspective in JAMA, which should be coming soon, which is essentially saying that the measurement of ambient is wrong, right? Like the current measurement of ambient is wrong. So there's two reasons for it. So fundamentally, the ambient measurement has been specifically used at what I would call a pre-post approach, not looking at the encounter level. So what you're seeing is that you have a pre-period in which the folks did not have ambient use, and a post-period when they had a mixed ambient use. Some percentage of the users used ambient at 60%, some used at 5%. So there's a combination of factors that are associated here. So those pre-post comparisons really doesn't get you into, so 90%, I want to say 95% of the studies except one study has shown that there's really no difference in time. So what is really happening? And across the board, every study has shown that there is reduction in burnout, better experiences. So what is going on, right? Like, so that is fundamentally because of what I would call Robert McNamara, who was the defense secretary in the 60s, this idea of measuring whatever is easier, right? Like the easiest measurement mechanism, very quantitative approaches. Here's signal, let's do the measurement, and there's no difference, right? So we've started doing it at the encounter level, and we found like there is a significant difference in time. Like there is a significant difference, but you have to look at the way in which we have to look at, and that's where the understanding of audit logs becomes extremely important in studying these sort of constructs, right? It also brings into the account of really understanding that these human AI interaction mechanisms are complex, and we need to understand sort of the cognitive perspective of the interaction between them, as opposed to just looking at the numbers that come out of this. And yeah, I'm happy to talk offline if there are questions around that. But I'm happy to share Clarity code or whatever else you need.
Wonderful. Thank you so much. I see. Do you have a question there? Your hand is up.
Yeah, I had a quick
Yeah.
question. With regards to, first of all, great talk. Thank you for taking the time for it. Regarding choosing outcomes that are more generalizable across different sites and whatnot, there's a lot of there can be site-by-site variation in terms of like how certain sites practice certain ways
Yeah.
of delivering care. So were there ever instances where certain sites you'd work with would come to you and say, hey, is there some sort of like way to proxy or like incorporate a more
Yeah.
site-specific outcome of interest into like the
Yeah.
analyses?
Yeah, I mean, yes. This is the hard part of audit log based research, right? Epic is a custom installation across sites. So what you see at New York Presbyterian in terms would generally be the same in terms of interfaces and workflows, but the back end looks very different. How you put in an order is different in how it's stored. So understanding those differences could take like a deep understanding of where to look for and the metrics and the IDs, right? So I would say the 2 or 3 groups nationally, the UCSF folks, like I know how it works at UCSF, like at every level, right? If you're using these sort of studies. But it's not the same in Mayo or at other. So that initially becomes a challenge. So if you wanted, like the example I was saying about the nursing turnover study, right? I don't think we can give you the same code and it'll work in the exact same way because the workflows differ. Also, there's also workflow changes with respect to behavior. So, for example, there could be a nurse documentation tool using ambient. Like some of the institutions have started using that. That'll change how the flow sheets are written, right? Like so, the outcomes have to be very carefully sorted out. And I'm going to be a sort of a pessimist here and sort of using this as a generalizable mechanism for addressing every sort of outcomes that we can do. I mean, just the point of providing the burnout example was not to say that we're really good at measuring burnout. It was just the opposite. It's like we can't, and this is really hard. And some of these things, like for example, turnover is a very complex multifactorial problem, and it becomes very hard to do it. I don't know if I answered the question, but it's really hard, and it's done on a case by case basis.
No, that does. Thanks for answering it so detailed.